Hello, everyone, and welcome to the topic on oral cancer. So, at the outset, I would like to present to you the latest, according to WHO, on cancer. So, first of all, cancer is the leading cause of death worldwide, accounting to nearly 10 million deaths in 2020, or nearly 1 in 6 deaths that have taken place in up until 2020. The most common cancers are breast, lung, colon, and rectum and prostate cancers. Around one third of deaths from cancer are due to tobacco use, high body mass index, alcohol consumption, low fruit and vegetable intake, and the lack of physical activity. Cancer causing infections such as human papillomavirus and hepatitis are responsible for approximately 30% of the cancers cases in low and low middle income countries. And lastly, cancers can be cured if detected early and treated effectively. So this is a screenshot from the WHO fact sheet on the lip and oral cavity related cancers. And as we can see here, the lip and oral cavity cancers come at number 16th among all the cancers that take place that occur in the human body. And the overall incidence as reported as of 2020 stands at 377,000 cases. Okay, and when we look at the number of deaths, also oral lip and oral cavity come at number 16 in terms of the various cancers that occur in the human body that lead to mortality, with a staggering number of 177,000 deaths plus. So let's look at the status in terms of Malaysia. And in Malaysia, lip and oral cavity cancers come at number 19, right, among the top 20 cancers in the human body. And as of 2020, the total number of cases that have been reported for the year 2020 stands at 742 cases, with an incidence rate of 1.5%. And the total number of deaths for the in the year 2020 were 403, which is approximately 1.4% of all cancer deaths that have taken place in Malaysia. So the crux of the problem, despite the fact that the oral cavity remains one of the most accessible parts of the human body and one of the most frequently visualized part of the human body, the fact remains that when we look at the statistics published on cancers in terms of staging of all cancers in Malaysia or anywhere around the world, this seems to be the most important problem. And what exactly is that? The problem is that majority of the patients, okay, please pay attention to the percentages here at stage 4 and stage 3. Majority of the patients come in stage 4 and stage 3 of the cancer. So they are detected at a late stage, despite the fact being that the oral cavity is one part of the body which patients brush every day. They can visualize it every day in a mirror, and we can screen it every time they visit a dentist. But the issue remains that majority of cases get detected in stage 3 and stage 4, thus being at a later stage and at a difficult stage when cancer cannot be cured. So this is a pie chart from OCRCC website way back as reported in 2007, and between 2007 to today to 2022, nothing much has actually changed in terms of the staging at which patients report, and even today majority of the cases report at stage 4 and stage 3. So this is basically the crux of the problem, because of which we as oral healthcare providers have our most important duty here, that every time we have a patient who visits us, we do a thorough oral examination and screening with the intention to detect most lesions at stage 1 and stage 2 so that we can prevent those cases from becoming cancer, right? So as I've explained many times in my lecture as well as in class, I have always said that we as oral healthcare providers as well as dental surgeons, our uh, our victory is not when we have detected a full-blown cancer, a large lesion on the tongue, but in fact our victory is when we should have been able to detect that lesion when it was a red or white spot many weeks or years ago, when it was a red or white spot on the tongue, when it would have been in stage 1 or even probably been just an oral potentially malignant disorder with mild dysplasia, right? So having understood the crux of the problem here with respect to oral cancer, let's now look at squamous cell carcinoma. Now, why are we looking at squamous cell carcinoma? Because squamous cell carcinomas are the most commonest neoplasms of the oral cavity. That means out of all the oral cancers that take place, 90% of them are all squamous cell carcinomas. So by definition, according to WHO, squamous cell carcinomas are invasive epithelial neoplasms with varying degrees of differentiation and a propensity to early and extensive lymph node metastasis, occurring predominantly in alcohol and tobacco using adults in the fifth and sixth decade. Right. So when we look at epidemiology, it's more common in males as compared to females. Globally, is it's among the 20 most commonest cancers as of 2020 statistics. So elevated rates are seen in French-speaking Switzerland, northern Italy, central and eastern Europe, and parts of Latin America. Okay, men is equal to women in South Asia. In the US, black men are more common than white men, and in Australasia, there's a very high incidence of lip cancers because of their exposure to UV light based on their geographical location. Right. Now, I'd like to add here that globally, the highest number of oral cancers take place in South and Central Asia collectively, followed by East Asia. Etiology, when we look at the etiology, tobacco chewing, tobacco smoking, and alcohols is the most common etiology. HPV infection, which is human papillomavirus infection, type 16 and 18, has also been attributed to oral cancer. Diet and nutrition, less in fiber, less in fruits and vegetables, vitamins and minerals is a common cause of cancer, similar to other cancers in the body, and occupational risk. So let's now look at the molecular mechanisms that affect the pathogenesis of oral cancer, right? So for that purpose, first we need to understand the concept of oncogenes and tumor suppressor genes. So oncogenes are growth promoting genes which are called proto-oncogenes in normal cells, right? So they're called proto-oncogenes in normal cells. But when mutation occurs, okay, in these proto-oncogenes, it leads to uncontrolled cell growth. On the other hand, tumor suppressor genes, they present in all normal cells. They code for proteins that regulate cell proliferation, and mutation of these genes leads to uncontrolled cell growth, right? So the cancer is always uncontrolled cell growth, and both these two factors play a very important role in the molecular mechanism of cancer. Okay, so under normal circumstances, cell proliferation is controlled by the balance between growth promoting genes, okay, and growth inhibiting genes. That means there is a balance between proto-oncogenes and tumor suppressor genes. But in carcinogenesis, what happens is proto-oncogenes may undergo mutation and become an oncogene, and tumor suppressor genes may be mutated or their products inactivated, ultimately resulting in uncontrolled cell growth, which is cancer, right? So this is the central dogma to the concept of molecular pathogenesis of cancer. Now, this is a diagrammatic representation of the cell cycle and the cell cycle checkpoints, right? So, as you are aware, right? So, this there you have G0 phase, which is the resting phase. Thereafter, the cell enters the G1 phase, right? And just before the cell moves from G1 to the synthesis phase, which is the S phase, you have these checkpoints, which basically regulate the cell cycle, right? And between from this S phase, it moves into the G2 phase, right? And from the G2 phase into the M phase, which is the cell division phase, right? So at all these interphases, there are checkpoints. So let's look at what happens at these checkpoints. So this is a diagrammatic representation of the normal cell growth and what happens in the cell cycle. So the cell enters is in gap 1 stage, which is the G1 stage, where there is cell growth. Okay, when the cell growth takes place, the checkpoint here is basically the proto-oncogene, right? So the proto-oncogene, which prevents the cell from undergoing a mutation or becoming a cancerous cell, right? Between G1 to S, the checkpoints are the checkpoint is the tumor suppressor gene that prevents the cell from undergoing cancerous mutation, right? If, however, there is still a cancerous mutation that takes place, right? So there are some things called DNA repair genes that are present in the cell in genes, and they try to prevent they act and prevent the cell from undergoing a cancerous change. And thereafter, when all these checkpoints have cleared the cell undergoes mitosis and a normal cell division takes place. So when we say normal cell division, a single cell divides into two cells in a normal mitosis. Okay, so let's look at what happens when cancer carcinogenesis. Right. So at this checkpoint, what basically takes place is that if there is a genetic mutation that is identified, right, by the checkpoints, right, then either the cell undergoes cell cycle arrest or DNA repair genes repair the gene and the cell progresses to mitosis, or if it is a damage that cannot be repaired, then programmed cell death is activated, and these genomic maintenance mechanisms prevent a normal cell from turning into a cancerous cell. Okay, only when these mechanisms actually fail does the cell actually undergo a cancerous change. So let's look at what those changes are. So abnormal cell growth takes place when proto-oncogenes get converted into oncogenes, right? So this is a diagrammatic representation of the chromosome, all right, of the chromosomes here, and it has been the anomaly, the simile that has been given here is that of a racing car, right? So under normal circumstances, you have normal genes which regulate the cell growth. It's similar to a car that is driving at normal speed, right? Uh, Following a mutation, right? Let's say the first mutation, it leads to accelerated cell division. That means a proto-oncogene gets converted into an oncogene. So that is similar to a driver, actually, the car losing control and acceleration becoming uncontrolled. So with that, what's happening is that cells are dividing faster. When we look at tumor suppressor genes, under normal circumstances, these tumor suppressor genes, they regulate the cell growth, right? So if a mutation that leads to the activation of deactivation of tumor suppressor gene, then it's actually going to lead to then the situation that's going to occur is that there is an active oncogene, right? Again, which increases the rate of cell growth. So here we have tumor suppressor genes and an active oncogene, right, which is already present. A second mutation that occurs on the chromosome will lead to something similar to no brakes, right? That means a failure of the brakes. That means there is increased acceleration plus there is a failure of brakes. That means there is no ways that cell division can be controlled. Then it leads uh, uh, to cancer, right? So basically what happens here is a normal cell would have divided in this way. If there is a single first mutation, then the division would have taken place in this way. If there is a second mutation that has taken place, then one cell actually ends up multiplying into more than two cells, and multiple cells are formed, thus leading to malignancy or malignant cells. So for cancer to arise, we need just one cell to undergo an irreversible mutation and to go through the checkpoints of cell division. That means the activation of oncogenes, the suppression of tumor suppressor genes, which ultimately leads to cancer. Okay, so now this is the molecular model of dysplasia and carcinogenesis for oral cavity. So here we have a normal cell. So the first change that takes place for a normal cell is a loss of heterozygosity, okay, on 9p. So here 9p is basically ninth chromosome. P stands for petite, short arm, and Q stands for long arm. Okay, so this is the nomenclature that is used for chromosomal nomenclature. Okay, so basically when we look at uh, a chromosome, this is how we actually we draw it. So it has a short arm and it has a long arm. Okay, so this is P for petite, okay, which is French word for small. And because the chromosomal nomenclature is given by the French, American, and British, so since the French took the Q, the American and the British said that the long arm is going to be Q. All right. So this is how you actually decipher these loci for chromosomes, right? So 3p means chromosome number 3, short arm, chromosome number 17, short arm, so on and so forth. Okay, so let me first explain this. So the molecular model basically explains that a normal cell to become hypoplastic undergoes loss of heterozygosity, okay, and there is a mutation that takes place at chromosome number 9 in the short arm, right? So when this takes place, epithelial cells undergo a hyperplastic change, right? Thereafter, if the individual continues to be exposed to the carcinogens, right, the subsequent mutation takes place. So you have 9p that has taken place. The next mutation that takes place is a mutation on 3p and 17p, right? At this stage, basically, the hypoplastic cell has moved into a phase of dysplasia. Now, dysplasia, as I've explained in my previous lectures, is basically is the abnormal cell proliferation that is taking place. And as I've explained, as the concept of oral cancer, right? Every oral cancer at some point in time would have been a small red or white spot in the oral cavity, which could be detected as early as mild dysplasia, right? So when we are talking about mild dysplasia, clinically mild dysplasia, what it means is molecularly this is the mutation that has taken place, right? So mutations are always cumulative, right? And as more mutations take place, the more progress from mild to severe dysplasia will take place, right? But the jump from severe, all right, from severe to carcinoma in situ and cancer takes place when one, two, three, four, five, six chromosomes undergo a mutation, right? So four, chromosome number 4, 6, 8p, 11q, 13q, and 14q. So thereafter, this is progresses towards carcinoma in situ and oral cancer, right? So the fact remains that at this stage, all right, at the hypoplastic stage, if the irritant or the carcinogen exposure is removed, right, the patient is has a very high chance of the mucosa turning back to the cells turning back to normalcy, right? So why if the patient does not stop the habit and continues to be exposed to the carcinogen, then every subsequent exposure has a risk of a mutation, and every mutation becomes a accumulation of uh, of mutations, which eventually is leading to the activation of oncogenes and the suppression of tumor suppressor genes and the inactivation of DNA repair genes. So, if you now that we've understood the molecular mechanism of oral cancer, right? Now, P53 is a protein, right? Which is coded at 17P, all right, and it functions as a cell cycle regulator, which acts as the G at G1 and S checkpoint, right? So now we are again relating this whole concept back to the cell cycle checkpoints that we had actually discussed. So normally this P53 detects the DNA damage and arrests the cell cycle, right? So that is why P53 is a very, very important protein in to prevent epithelial neoplasms, okay, to prevent carcinomas. Now, this mutation of P53 leads to a loss of regulation of the checkpoint, allowing cells with damaged DNA to undergo replication, leading to cancer. Thus, mutation of P53 is a common and significant event in oral cancer and many other cancers in the body. Okay, so P53 is coded at 17P, all right, and if you refer back to the previous slide, which I have just shown, that is when mild dysplasia is moving to severe dysplasia, and eventually the whole process is becoming irreversible. Okay, now this is some facts and figures. This is a screenshot from the past, but I just want to show here something very important which has been put up in the research for oral cancer in Malaysia. All right, it has been noticed that more recently, oral cancer is increasingly being diagnosed in individuals who do not have risk habits. Okay, and although oral cancer can be fairly easily detected, death rates are higher than that of many other cancers types because it is often presented late. So, which is the crux of the problem. And another important fact, which I'm trying to tell you through this slide, is that there is an increasing incidence of oral cancer, not just in Malaysia but globally as well, where you have patients who do not have habits. That means are not tobacco users or alcohol users, and are still developing oral cancer. So there is a big, wide area for research that is still open for all of us. Okay, so let's look back at the common sites. So, oral cancer, most commonly lips, buccal mucosa, followed by buccal mucosa, gingiva, hard palate, anterior two-thirds of the tongue, including dorsal, ventral, and lateral surface, and the floor of the mouth. Clinical features, they may present as red, white, or red and white lesions. Okay, mucosal growths and ulceration, pain, referred pain to the ear, malodor, difficulty in speaking, opening, chewing, swallowing, bleeding, weight loss, and neck swellings. Okay, so please pay attention to this. Occasionally, it could present only with an enlarged neck node and an asymptomatic oral lesion, right? So this explains the reason why complete oral examination and the palpation of the neck is a very, very important step that dental surgeons need to do every time a patient comes then. So here, this is a red lesion here on the tongue, right, on the floor of the mouth, closer to the frenal attachment. Okay, this is a white lesion, right? There's a white lesion on under the surface of the denture, right, which when biopsy turned out to be oral cancer. Okay, this is a lesion on the lower lip, right, showing crustaceans and rolled out margins. Again, turned out to be oral cancer. So what I'm trying to tell you from these images is that different patients have different presentations. Sometimes it could be a small lesion small in size, right? Sometimes it could be a very large lesion, like this one, right? So this is a huge lesion, right? 5 by 4, roughly more than 5 centimeters in size, right, affecting the lower lip as well as the upper lip. So technically, all these lesions would have been small red or white lesions many weeks or years ago. And if the patient would have come to a dentist at an early stage, we should have been able to detect it. And our success would have been to identify this lesion when it was very small and preventing this from becoming such a big lesion. And detecting and treating it early is our success. Right. So having understood the molecular mechanism, the clinical features, right? So it's important for us to understand the histopathology, right? So histopathologically, oral squamous cell carcinomas are graded as three types, right? Well differentiated, moderately differentiated, and poorly differentiated. Okay. So well differentiated are basically where the cells resemble the cell of origin. Okay, and as we go from well to poor, basically the cell of origin does not the cell of origin becomes difficult to be identified. So that is what it means. So well is when you see sheets or nests of cells of squamous origin which have broken the basement membrane barrier and inverted into the connective tissue. So the cells show increased amount of keratin production in the form of keratin pearls of varying sizes. There's nuclear hypochromatism and less mitotic figures here, right? Moderately differentiated, on the other hand, the cells show less resemblance to the cell of origin. There's lesser amount of keratin formation as compared to well differentiated, and there is increased anaplastic features. So when we use the word anaplastic features, basically it covers all the features of dysplasia that we are able to see. That means increased mitotic figures, increased nucleocytoplasmic ratio, abnormal mitosis, so on and so forth. Poorly differentiated, which is the third type and the most dangerous type, is where there's rapidly dividing cells, there's bare minimal resemblance to the cell of origin, there's no keratin formation, and we see highly anaplastic features. That means they're very, very high cancerous features and that we are able to see. And the cell of origin does not look similar to the squamous cells, okay? And there is no keratin that we see over here. So the implication here is if the diagnosis is a well-differentiated squamous cell carcinoma, the patient has good prognosis. Moderately differentiated is fair prognosis, and poorly differentiated has poor prognosis. So this is a histopathological picture, right? This is low power image and this is the high power image. So if you look at this is normal epithelium. As we move closer here, we're able to see the break in basement membrane and the proliferation of the cancerous cells into the connective tissue. This is the high power picture of the same thing. As you look here, you can see that there is whirling of the cells, right? And there are islands and sheets here. And in the center of it, you can see keratin formation. So this pink pearl that you notice at the center is basically produced by these anaplastic cells, cancerous cells, which we can clearly identify as squamous in origin. And this is a deeper section and a clearer image of well-differentiated squamous cell carcinoma. The dark pink whirling that you see, this is keratin pearls. This is described as keratin pearls. These are islands of cancerous tissue. Right here, they are invading the muscle. Around it, all these blue dots are the inflammatory response that you notice. Okay, so here, because there is large amount of keratin that is produced and the cells resemble the cell of origin, this is graded as well differentiated squamous cell carcinoma, and the prognosis for this patient is good. On the other hand, here we have another case, another histopathological image. This is normal epithelium here. This is the cancerous proliferation and invasion. As you see, it's coming closer to the muscle bundle. So it's come deeper into the connective tissue. As you look here, there's very less keratin compared to the previous slide, right? Just this one over here, 2 and 3, but the cells can still be identified as resembling squamous cells, right? Their features can still be identified, and this was diagnosed as moderately differentiated squamous cell carcinoma. On the other hand, this is an image of poorly differentiated squamous cell carcinoma. This is the break in basement membrane, and you can actually see the proliferation of cells in the connective tissue. Here, the cells are more singular, right? We do not see the islands or the whirling here, right? This is the high power image. These cells look more like in a single file kind of an arrangement. Okay, they show all the anaplastic features. There is an immune response around this cancer, but there is no direct information, and the resemblance to the squamous cells, the cell of origin is lesser, right? And this is diagnosed as poorly differentiated oral squamous cell carcinoma, and for the patient, this diagnosis of poorly differentiated is indicative of poor prognosis. The reason being that the proliferation here is more rapid, right? More dysplastic features, it spreads more rapidly, and thus the prognosis is poorer. Okay, so when we look at the concept of oral cancer, right, we need to also understand the TNM classification, which stands for tumor, node, and metastasis, all right? And this TNM classification and staging helps us to determine the prognosis for the patient, okay? Now, T stands for the primary tumor and is categorized as Tx, T0, Tis, T1, T2, T3 based on the size, all right, based on the size of the clinical lesion. And we also have T4A and T4B, which covers the lip and the oral cavity. Okay, so this is how it is described, and based on the clinical appearance and examination, we are able to categorize the T. Okay. So N stands for node, okay, the assessment of the regional lymph nodes. So NX is when the nodes cannot be assessed, N0 is when there's no regional metastasis, N1 is metastasis in a single ipsilateral node that is on the same site, which is less than 3 centimeters. N2 is when is further subcategorized as N2A and N2B and N2C, all right, where there's metastasis. N2A stands for metastasis in single ipsilateral node greater than 3 centimeters but less than 6 centimeters. N2B metastasis in multiple ipsilateral nodes not more than 6 centimeters. And N2C is metastasis in bilateral or contralateral lymph nodes not more than 6 centimeters. Lastly, N3 is metastasis in a lymph node more than 6 centimeters in greatest dimension on either side. So ipsilateral is same side, contralateral is the opposite side, right? So when we say same side, it is in comparison, it is in relation to the site of the tumor. M stands for metastasis, and MX, under that, MX is when you cannot assess metastasis, M0 is there's no distant metastasis, and M1 is when there's distant metastasis. So here I'd like to mention that the M, to assess the M, we need to do imaging studies like PET scan, where in the full body PET scan is done to analyze if there is metastasis, distant metastasis, right? So only then we have done a complete diagnostic workup, and we will be able to come up with the TNM staging. So TNM, which is tumor node and metastasis staging, is a clinical staging, right? So when we say the patient is at stage 0, it means that it's TISN0M0. Stage 1 is T1, where the size of the lesion is less than 2 centimeters, right? There's no nodal metastasis, or no lymph nodes detected or metastasis. Stage 2 is lesion greater than 2 centimeter. Stage 3, we have these two combinations, and stage 4A, 4B, and 4C. These are the various combinations, right? So our success as oral healthcare providers, again, I'm again and again emphasizing, is to be able to detect patients in stage 1 and stage 2, right? That is when the size of the presentation is much smaller. So either as a red lesion, red spot, or a white spot. When we notice it, we biopsy it, and we come up with we identify the diagnosis and treat it early, right? If we diagnose the patients at stage 4 or stage 3, the prognosis is poor, and most patients in stage 3 and stage 4 do not make it through the 5 years survival. So treatment and prognosis, Tnm classification and staging is most significant for prognosis. As I said, histologically, I've already mentioned, well differentiated has good prognosis, moderately differentiated a fair prognosis, and poorly differentiated has poor prognosis. So surgical excision with radical neck dissection is the standard of care. Radiation therapy, post-operative radiation therapy is also used for oral cancer patients for the treatment of oral cancer. And there are variants, histological variants of squamous cell carcinoma, right? Under that you have varicose carcinoma, basal large squamous cell carcinoma, papillary squamous cell carcinoma, spindle cell carcinoma, acantholytic squamous cell carcinoma, adenosquamous carcinoma, and carcinoma queniculatum, right? This is good to know information as undergraduates. Okay, I will further be elaborating about varicose carcinoma out of all the variants here. So verrucous carcinoma, it is an exophytic, warty, slow-growing variant of squamous cell carcinoma with pushing margins. And that's why it's different from the conventional oral squamous cell carcinoma. It's common in older males, okay, and the etiology, most of these patients are users of smokeless tobacco, that is chewing, right? HPV-16 and HPV-18 has also been identified as one of the etiologies for verrucous carcinoma. Common site is buccal mucosa followed by gingiva, rarely the hard palate and the floor of the mouth. Clinical features, the patient presents with exophytic papillary white lesion having folds and cleft, and these lesions many times could be very extensive, all right? So here, this entire white lesion here that you see, this exophytic white lesion that the patient presents with, okay, turned out to be verrucous carcinoma. And this is another patient here, such a white lesion infecting the buccal mucosa, the vestibular mucosa, as well as the mucosa under the palate, under the denture bearing area. Okay, on biopsy turned out to be a verrucous carcinoma. Microscopically, the difference is that here epithelial proliferation with downgrowth into connective tissue is seen without invasion. Right, so very broad-based retipex, which are described as elephant leg shape retipex. Okay, with parakeratin plugging is the hallmark for the diagnosis of verrucous carcinoma. There are very few mitotic figures, nuclear and cellular pleomorphism is also less. Okay, and the treatment for this case, these patients, is wide surgical excision. The good news is, in comparison to conventional oral squamous cell carcinoma, verrucous carcinoma has better prognosis. This is the microscopic presentation. So this is the elephant broad-based retipex or elephant foot-shaped retipex, all right, and it destroys the tissue with a pushing margin, all right. So this whole thing moves in, or rather walks into the connective tissue, as against oral cancer, conventional carcinoma, where the basement membrane breaks in and the cell proliferation takes place. This is the parakeratin plugging that is seen as a hallmark for the diagnosis of verrucous carcinoma. Okay, now let's look at malignant melanoma, right, which is another oral malignancy of epithelial origin, which is common in the oral cavity, all right. So neoplasm, it's a neoplasm of epidermal melanocytes, is the third most common cancer of the skin. Okay, 3% of all cancers of the skin are malignant melanomas. The rates are high in populations where Caucasians predominate. Highest number of cases are seen in Australasia, all right, North America, Northern Europe, Western Europe, and Southern Europe. Etiology is exposure to UV radiation. Now this is a graph showing the incidence, the higher incidence of malignant melanoma in the Australasia and Northern Europe region. Okay, but that doesn't mean that it does not affect Asia. It also does affect Asian regions, including Southeast Asia. The most commonly affected site of skin in both sexes is the face in males. Okay, it is also the ear. The other sites are back and shoulder in men and lower limbs in female. Now, the growth of melanoma has two phases. One is the radial phase, and the second is the vertical phase. Okay. So in the radial phase, the tumor cells basically proliferate laterally, okay, and whereas in the vertical phase, the tumor cells basically break the basement membrane and proliferate into the connective tissue vertically, perpendicularly. Okay, so that is the difference. This is malignant melanoma of the skin, okay, of the head and neck region. So this is the change in color that you are noticing over here, right? And you can see that the margins are irregular. So this is more or less that this would have been the nevus, which has undergone malignant transformation, and this is the radial face of the lesion. As here the color and intensity has increased here, okay, and you cannot actually see the spread of the change in color in the surrounding skin, okay. So more likely, as the color intensity is increasing, it's more probable that there is a vertical phase of growth that is taking place over here. So this is another image of malignant melanoma of the skin. In the oral cavity, hard palate is the most common site. Okay, so here you see an edentulous patient with a large lesion in the anterior hard palate. All right, but we also see the, the the color changes in the posterior hard palate as well as surrounding area. So basically, here what has taken place is the lesion is spreading laterally, and technically, this lesion histopathologically would have already involved most of the hard palate. And for your information, malignant melanomas are highly malignant and proliferate very rapidly. And oral malignant melanomas have very poor prognosis because they grow rapidly and metastasize rapidly, causing massive destruction and rapid progression. So the clinical criteria for diagnosis that is used is called the ABCDE rule, where ABCDE is abbreviated as A for asymmetry. That means if there is a nevus which shows a sudden change in color because of asymmetry, then and you notice asymmetry, then we should be get suspicious. An irregular border, B standing for border, uneven color for C, diameter greater than 6 millimeter, and elevation on the surface is clearly a clinical criteria to categorize or to suspect malignant transformation of a nevus into malignant melanoma. Oral manifestations, as I said, it's common in the palate, where most commonly, and the maxillary gingiva. Oral lesions are intraoral lesions are rare, okay, but whenever they do occur, they have very high rate of metastasis. Here, this is a picture just to reflect on the ABCD. So A stands for asymmetry, clearly asymmetrical lesion. B for irregular borders, right? C for change in color, okay. D for diameter greater than 6 millimeter. E for elevation on the skin. So all A, B, C, D, E, all five clinical criteria are fulfilled in this change here. Very highly likely that this is malignant melanoma. Histopathologically, in a case of malignant melanoma, there would be malignant cells seen in clusters or nests. They have large nuclei with prominent nucleoli. These are called as atypical melanocytes. Okay, you have two types of cells in the category of atypical melanocytes. One which are epithelioid indicating they look like epithelium, and the second is spindle shaped, which look like more like fibroblasts. Okay, so this is a microscopic photomicrograph of a case of malignant melanoma. This is the overlying epithelium. This is the connective tissue, and all these brown cells that you actually see are all atypical. A high power picture here, you see large cells with dark blue nucleus, right? Nuclear hyperchromatism, varying size and shapes of the nucleus here, which is nuclear pleomorphism, right? You also see mitosis here, and you see large amounts of melanin pigmentation, right? This is a picture from Science Photo Library, which shows the immunohistochemistry staining that is done for for malignant melanoma, clearly indicating that this is a case of malignant melanoma. So the treatment for malignant melanoma of the oral lesion would be surgical excision and neck dissection. Right. Other treatment modalities are cryosurgery, radiation, immunotherapy, and chemotherapy. Prognosis indicator 5-year survival (FYS). Okay, depends on the histological type and the depth of invasion. Right. Melanomas more or less have very poor prognosis. There are two systems that are used to actually assess the grade of the tumor based on the deepest histological structure that has been invaded, which is called the Clark system, and the grade on the thickness of the tumor invasion from the stratum granulosum, which is called the Breslow system. Both these systems are difficult to apply to the oral lesion. Also, the ABCDE clinical criteria is more commonly applied for skin as against the oral cavity. Right, so this brings us to the end of this lecture, and I would like to leave you with the with this media image from the WHO, which summarizes the ways in which we can reduce our cancer risk. Number one here is do not smoke or use any form of tobacco. Make your home smoke free. All right, please try and motivate your friends, relatives, and to give up smoking and the use of tobacco. Enjoy a healthy diet, a balanced diet, right? It's also been proven that breastfeeding reduces the mother's cancer risk, okay? And vaccinate your children against hepatitis B and HPV. Avoid too much sun and use sun protection. Reduce indoor and outdoor air pollution. Be physically active. Limit alcohol intake and take part in organized cancer screening programs, right? The crux of the issue of matter in terms of cancers, all cancers in the human body, is that 30 to 50% of all cancers are preventable if they are detected early. Okay, so together, let's beat cancer. Thank you very much.